Greetings. I am Dr. Yash Patel. I am here for Project Krishna. This is a wonderful topic regarding HBA1C, whether to focus to get it below 7. So the today's topic is HBA1C less than 7 for friends with type 1 diabetes. Is it dream or reality? So today's topic, which I have taken into the one of the international conference that I am going to represent. And that's where we would see into what are the ways we can contribute back for specifically in showing that how we can reduce A1C and what A1C target is appropriate for the same. So let's do needful. So I acknowledge Swasthya Diabetes Care. As a consultant, I am part of this Swasthya Diabetes Care and All India Institute, which is Center of Excellence for Diabetes Care as well as Center of Education for Diabetes Care by certified by IDF. Even ISPED Sweet Body has recognized Swasthya Diabetes Care as well as All India Institute of Research as Center of Reference as well as Center of Collaboration for Pediatric Diabetes. I did my fellowship at UBMD under Dr. Dendona, where I have worked for a JDRF funded project. That's in the background. I'm a consultant for Make My Life project, which is the project to empower type 1 children for medical treatment as well as psychological career and marriage counseling is also part of Make My Life project. Swasthya as well as All India Institute of Diabetes and Research is a certified insulin pump center and that has adopted CGMS and insulin pump, one of the first center in Asia. Our one of the consultant is also part of Young Leader in Diabetes, appointed as Southeast Asia's YLD representation, and Project Krishna, where you all are part of it. In Project Krishna, we train all medical as well as paramedical doctors or paramedical workers, healthcare providers to take care of medico-social communication of type 1 friends. So today's talk agenda is also focus on objective of feasibility and challenges to achieve HbA1c less than 7% in type 1 diabetes across various patient profiles. So understanding the feasibility and challenges for the same. The talk is phased into this segment and we'll see over time. We all know the survival of type 1 friends have increased over last 5 to 7 decades and that has been commendably noticed after DCCT trial. The definition of HbA1c, we know it is an average glucose representation for last 2 to 3 months, and the importance of it is long-term glycemic control representation, and it has high correlation with complications. The clinical target below 7% is considered optimal for type 1 friends. And to minimize complication while balancing the risk of hypoglycemia is one of the factors. A1C's advantage is more over fasting plasma glucose or oral glucose tolerance test for providing long-term average glucose level understanding and widely used and accepted metrics in glycemic control. But A1C as a biomarker provide an average and is not always reliable. In cases of hemoglobinopathies, anemia, uremia, ethnicity, HbA1c is not reliable. Even it fails to provide data regarding hypoglycemia as well as glucose variability. So evaluation of glycemic management from A1C to triad of glycemic marker, improve glucose level as well as avoid hypoglycemia and glucose variability limiting is shifted, and from there to newly glycemic target, time in range is focusing. So what is time in range or targets in range? So that is 70 to 80 milligram of deciliter of all 24-hour glucose above 70% of time duration. Above 180 is considered time above range, milligram of deciliter, that to be restricted below 25%, and below 70 milligram per deciliter to be restricted in total days time below 4%. So if we see the time above as well as time below, is also need to importantly interpret also. And that time in range through CGMS focuses on capture of all glucose levels and identifies time it is very within in a safe range. So 100% glucose in target is possible with this. When we see current guideline and real world outcomes, ADA, ESD, ISPED recommend individualized target, but generally endorse HbA1c less than 7% for adults. Data show that only about 20 to 30% of friends with type 1 diabetes achieve their target. Even this variation of population, basis of age group, socioeconomic status, geographical region, there is a wide disparity across different regions. Even before 1980, the aggressive therapy was considered unsafe. Even it was of unknown benefits. And that's where HbA1c in type 1 were focused to keep between 11 to 12 percentage. Even eye and kidney complications were higher at that time. But DCCT showed 76 percentage improvement in microvascular complications through tighter glycemic control. And that's where post DCCT, early tight glycemic control has been focused to reduce microvascular complications. Even ADA in June 2019 represented the glycemic target to be based on individuals' key patient features or disease features. And that included life expectancy and burden of disease as one of the stringency of glycemic control targets or important variables to decide for stringency of target. After that, international consensus on time in range came down, which showed clinical practices importance, both for appropriate and useful as a clinical targets as well as outcome measurements. And that was competent to A1C for a wide range of people with diabetes. And it has showed and I'll say endorsed by different associations as well as adult as well as pediatric associations. So what is time in range recommendation for type 1 friends? So to be kept time in range 70 to 180 percentage, total 70 percentage or above. Above range, so that is above 180 to be kept below 25 percentage and below 70 to be kept below 4 percentage. Even we see the older individuals of type 1 or high risk individuals of type 1 friends where the time in range targets are slightly less stringent, where even time in range to be kept up less than above 50 percentage but not as tight as 70 percentage, time above to be restricted below 50 percentage, and time below to avoid hypoglycemia to be kept below 1%. In cases of type 1 going through pregnancy, the target range is 63 to 140, where time in range to be kept above above 70%. If above target is greater than 140 milligram per deciliter, to be restricted below 25 percentage, and below range is considered less than 63, which to be considered to keep below 4 percentage. So what is this value determines? So time in range, every 10% increase in range is directly related to 0.8 percentage decrease in A1C. So 70 percentage represents 6.7 percentage of A1C. And if we increase this by 10 percentage time in range, the A1C reduction is by 0.8 percentage. The SAG study for type 1 friends have represented, though we focus less than 7 percentage, different part of the world, Asia, Eastern Western Europe, Latin America, Middle East. Till SAG study, the targets below 7 were not even achieved by 1/4 of the population. Even when we focus on individualized A1C target, then achievement was below 1/5 percentage of in this region. So what are the barriers and challenges to achieve HbA1c less than 7% in type 1 friends? So biological changes, we know variability in insulin absorption and action, hormone fluctuation, especially during puberty and pregnancy, socio-economical environmental changes, access to healthcare resources for cost of medications and diabetes technology is wise different. Health literacy and education gaps is almost very barrier to different population. Psychological barriers where fear of hypoglycemia is really considered too. Even diabetes, burnout, mental health issues like depression and anxiety are in line. Even technical barriers. What are technological barriers? So, what are those? Limited access to continuous glucose monitoring systems as well as insulin pump in certain part of the different regions. So, who is responsible for these barriers to not catching up A1C below 7%? Is it doctor? Is it friends with diabetes? Or is it tools or drugs or the healthcare providers or the pharma companies or the instrumental companies? Keeping into that consideration, what is base glycemic control system in the universe? So that is human physiology. Different our axis along with effective glucoreceptor neuro circuits. And that's where we need to focus how we catch up with the normal physiology as early as possible. So what are the successful strategies as well as innovations? Specifically personalized medicines, focusing on individualized treatment plan based on their socio-economical factors, lifestyle as well as behavioral factors. Even technological advancement using more SMBG, CGMS, insulin pump, automated insulin delivery systems, artificial intelligence as well as machine learning tools to predict glucose trends. Even education and empowerment, structured diabetes management, education and support program where peer support groups and psychological counselings are in the line. Even multidisciplinary approach, coordinated care involving diabetologists, endocrinologists, nutritionists, educators, even healthcare professionals could be at the base to success this. What are four critical times where diabetes self-management structured education program is important? When individual gets diagnosed with type 1 diabetes, or they are not matching up the targets, or their annual reports are not up to the mark, when transition in life or treatment is getting occur, or when complication sets in. These are the four major milestones where diabetes structured self-management and education support group is required in a line. Why so? Because at that time when we act well, the A1C target is achieved as early as possible, and that could be fulfilling to prevention of complications. Now, to focus into self-management with self-monitoring of blood glucose along with education is much more important. SMBG based on individual situations of the patient combined with adequate analysis of diagnostic data can support therapy optimization, desirable behavioral changes, and thus lead to clinical outcomes to the mark. The connected glucometers provide comprehensive diabetes digital solutions to motivate patients to be in the range. There are many meta-analyses and systemic reviews for mobile health solutions available, and that shows diabetes self-management application improve HbA1c, particularly those that provide a feedback loop between patient and healthcare providers. The data of different clinical trials showed that after 6 months, EHbA1c reduction from 7.24% to 6.49 with a structured monitoring of sugar. Even point in range has improved over 6 months from 69.8% to 75.3%, and points above range has been decreased with continuous monitoring. Ultimately, mean blood glucose decreases and glycemic variability decreases. Even in type 1s, the EA1C reduction is by 0.3%. Now coming to time in range. Through continuous glucose monitoring system, it is very easy for patient to understand where his or her sugars lies, and they are able to control it well. If we see the AGP reports where ADA has recommended to provide these AGP reports, when it is running continuously, they are able to manage it well. Even there are many evidence, clinical trials, meta-analysis, real-world evidence for continuous glucose monitoring system, which shows decrease in the A1C with CGMS, decrease in hypoglycemia, decrease in hospitalization, even increase in time in range with continuous glucose monitoring system has been noticed. The quality of life as well as satisfaction of individual increases with this continuous monitoring. Even the real world evidence shows decrease in the absentees of this type 1 friend in cases of where continuous glucose monitoring system has been used. Ultimately, it supports the clinical outcomes. So, education, self-monitoring of blood glucose, CGMS, inner soul monitoring, one part of the things to achieve HbA1c below 7. Now, coming to insulin therapy. We know basal bolus therapy is a gold standard for type 1 friends. So that is multiple daily insulin with long acting analogs, with rapid acting analogs as a bolus, or ultra rapid acting analogs as a bolus. Keeping that as a neutral, the flexibility and lower risk of hypoglycemia along with the cost involved. If we consider that neutral, then insulin pump without sensor is just adding the cost as well as a few flexibility. If we see insulin pump with threshold predictive low glucose suspension, the flexibility is more, lower risk of hypoglycemia is taken care, the cost increases. But what is more important is hybrid closed loop technology, which has more flexibility, which has lower risk of hypoglycemia, and the cost is higher as considered. If we see the daily activity of type 1 friends, from morning to sleep, there are plenty of tasks they need to do it, and those are challenges. Counting the daily bolus, delivering the bolus, correction of the bolus, along with checking the sugar, estimating the onboard insulin, estimating the carbs, taking the insulin 15 minutes per hour, all are in that line. And even the individual is exercising, then suspending the pump or temporary partial suspension, all in that line. So that has made the technologies, that has made with ease with technologies. The key transition from subcutaneous insulin infusion in pumps, from sensor augmented pump to closed loops to advanced hybrid closed loop, has been noticed into. And the technologies had evolved over a time, and that has made the individual's life much more easy. I'll share a real world observation study where multiple daily injections to automated insulin delivery, the time in range has improved in those individuals. And their observation shows that even time above range as well as hypoglycemia is decreased in type 1 friends in a real world scenario where glucose monitoring is done with sensor. If we see the transition of pump from mini-med to advanced hybrid system is noticed too, and that has supported the glycemic control with smart guard technology by suspending on low to before low, even auto mode hybrid closed loops has supported the delivery of basal insulin very well. When the sugars are falling, the basal starts decreasing. When sugars are increasing, the basal starts increasing. When there is a rapid fall, then there is a rapid suspension of basal. Even there is a rapid rise, then auto basal increase, as well as all these made automation the life of type 1 very much at ease. From multiple tasks a day for different meals to different exercise to the daily routine, the type 1's life has become with automation to much more at ease, from delivering the bolus to count the carbohydrate to preload the insulin. And the systems are widely available from Minimed to Tandem to CAM to Diabloop to Omnipod, all around. And that has made type 1 friends' life easy. But what are the challenges we have? Still, with all these advances, the A1C above 7% is prevalent in 75% of type 1 friends. They have when we try to get intensive control, they have weight gain as well as hypoglycemia. And 45% of these subjects have even metabolic syndrome also. And ultimately, they have mortality rates as well as CVD still higher than normal ages. So adjuvant therapies in type 1 had been tried, and this is one of the work which I contribute to UBMD, where pramlintide, metformin, SGLT2 inhibitors, GLP-1 agonists, as well as triple therapy has been looked as an adjuvant therapy for type 1. When we talk about pramlintide, the HbA1c reduction is by 0.4 percentage and weight by 1%, but it increases prick per day in type 1. Approved indication for type 1. But when we saw of metformin, the reduction of HbA1c is short term and weight loss of 1 kg. A slight decrease on insulin dosage has been noticed. Even some evidence suggests reduction in intima media thickening also. SGLT2 inhibitor, where dapagliflozin, sotagliflozin, empagliflozin have evidence. I'll talk about direct one study where primary outcome of change in A1C over 24 hours has been noticed with TAPA 5 and 10 milligram. Even the total daily dose requirement is also noticed by reduction 10 to 14% with this dapagliflozin. So reduction in HbA1c over 52% with 0.4% with 52 weeks by 0.4% along with weight loss and decrease insulin requirement by 10 to 30% notice with SGLT2 inhibitor. But it increases decay as well as genital infection chances. When we talk about GLP agonist with a focus on trial in UBMD, the liraglutide addition to insulin therapy in type 1 friends have shown the improvement in the time in range in CGMS. Even first prospective randomized trial involving liraglutide in type 1, where 72% randomized and 63 completed, which showed improvement in glycemic control with 1.2 and 1.8 percentage of liraglutide by 0.8 to 0.5 percentage, bringing those two in range below 7 percentage in these individuals. Even glycemic control, considering 70 to 160 milligram range in time in range, the percentage spanned in range has increased with 1.2, 1.8. Even percentage above the range has been decreased with 1.2 and 1.8 of liraglutide. Total daily insulin requirement in units by 9 to 10% or 10 units per day notice. Even postprandial glucagon change from 0 week to 12 weeks with 1.8 milligram has been noticed. Gastric emptying reduction reduced from baseline 0 week to 12 week with 1.2 usage as well as 1.8 usage notice in type 1. The adjuvant 1 and 2 where even C-peptide negative and positive individuals were compared with use of liraglutide and that showed significant usage. Even semaglutide in early type 1 diabetes is also explored and that gives positive inputs. But that has limited data. Now coming to triple therapy, insulin, GLP-1 and SGLT2 inhibitor. Dapagliflozin added to liraglutide and insulin patients and randomized and shown over 12 weeks, which gives finding of insulin therapy alone is not sufficient for improving glycemic control in majority of subjects with type 1 diabetes. So SGLT2 shows effect, but it increases the risk of decay and still is approval to adjuvant therapy is in warning chances. GLP-1 agonist consistent clinical benefits but may not get a label indication for type 1. Triple therapy in initial short-term studies gave much more better effects, but further investigation needed for large studies. Further investigation with GLP-1 agonist or triple therapy in C-peptide positive and newly onset type 1 is to be investigated in large trials. Now I'll share some of the clinical cases which are real world stories in success for type 1 friends. A 16-year-old friend with diabetes achieving HbA1c less than 7 through CGMS and insulin pump combined along with lifestyle intervention. This individual was previously on basal bolus therapy and then shifted to CGMS, then shifted to pump and then automated. Why in that background? Because a research publication was available in journal and when I reviewed it, the transition from type 1 friends to basal bolus SMBG to Minimed 780G was significant. Here, when the comparison I noticed with MDA and SMBG, the baseline as well as study, the improvement in Minimed from baseline to study was much more significant in time in range. And that's where historical stepped up care approach was thought into and where multiple daily insulin dosage with sensor initiated in this frame, then trial with insulin pump along with sensor, and after seeing the data of insulin pump the individual went to automated insulin delivery system, and here we have testing. The individual is taking previously was used to take 6 to 8 pricks a day. Now it's on insulin pump, and that insulin automated insulin pump has shown 100% time in range in this individual. Now he's focusing much tighter control, less glycemic variability, and that is one of the real testimony to our work. Case 2, an adult individual having low resources setting and achieving HbA1c goal with target of education and competitive work. To focus education community work, structured diabetes management as well as education and support program, we have created Project Krishna, where Krishnas are trained for medico-social communication to all four phases of diabetes care or education. And that's where they empower them well and mentor these friends in their critical time, from diagnosis to matching up the targets to setting up the newer care or the treatment to prevention of complications. And that's where they have achieved HbA1c less than 7 in this line. What are the third? Let's look into the third case. The successful management of type 1 lady going through pregnancy and maintaining HbA1c below 7 and delivering the healthy baby. That's what one of the real world cases. Here we use plenty of basal bolus, even the pregnancy treatment along with 780G insulin pump. And this shows how she is maintaining control over time. And these are real testimonies. The children are delivered with family. We have these testimonies of children who have been delivered, and that those are extension of Make My Life project, where not only clinical care, medical care, but they get empowered to live their life confidently. What are emerging trends and future perspective? Next generation technologies could be part into advanced closed loop systems, real-time CGMS data integrating with predictive insulin dosing algorithm, new insulin formulations, ultra-rapid acting insulins, as well as glucose-sensitive insulin in development, global initiatives, advocacy of equitable access to diabetes care technologies, and scaling up educational program globally. Even research directions, beta cell regeneration to stem cell therapies, as well as exploring the gene editing technologies for potential cures. Let's look into this diabetes structured medical education monitoring and education program for type 1, and getting into knowing that these individuals require support for sustainability. Project Krishna has been part of it, and now we are adding the sensory rich imagining reconditioning to this structured program, where improvement in behavior from inappropriate behavior to appropriate behavior by getting into their subconscious mind, where desirable thoughts to be focused with clinical hypnosis. This is in evaluation we are working on, that how sustainable program can be created. Even global collaborations with InPen with Simplera CGM, where these individuals were able to see monitoring with much cost effective, are looked forward. Medtronic announced this FDA approval of Simplera CGM and global partnership with Abbott. That the like such collaborations could be much more. Even cellular therapy. FDA approves first cellular therapy to treat patient with type 1 diabetes. Lentidra is one of the, and I'll give one of the Lentidra talk also in upcoming days for your background. So ultimately understand, type 1 diabetes care is not only patient and doctor's job. Whole health ecosystems are part of the system, from doctors to pathology, pharmacies, devices, telemedicine, medical insurance, patient supports to diabetes educators, exercising facilities to nutrition, nursing care, other specialties. And that not only do one time, it is lifelong care. So holistic lifelong health is much more to be focused. Diabetes care not to be focused only single point, it is ecosystem to be focused with values of empathy, empowerment, and evidence based care for everyone to everywhere around, involving all stakeholders to their best and excellent care. The collaborations for resources and infrastructure could be part into reach to all part of the world, and real-time research as well as aggregation of model is much more important. In short, when we talk about dream or reality for HbA1c, while achieving HbA1c is still challenge for many individuals, it is increasingly becoming a reality for those with access to right tools and support system. The call of actions are required to increase efforts for patient education, advocacy, and equitable access to diabetes management technology, and encourage more research as well as collaboration to make this goal achievable for all set of patients. In final thoughts, the dream of universal HbA1c control is attainable with continued innovation, comprehensive care, and patient empowerment. Look forward to your inputs for this talk, and I welcome you for to being part into Project Krishna. You can join us you can empower us to be part into. We look forward to in your support. Thank you everyone. Take care. If any questions you can share into, you can connect to us and get to the label. Thank you everyone. Take care.